Now I call upon Dr. Purvi for talking about, developing surgical skills, challenges and best practices.
Thank you, Dr. Bali, and thank you again, everybody, for being a part of this IC. And I'll be now talking on developing surgical skills, because when you enter the surgical branch, the MS word itself that fascinates is the surgeries that you do and the surgical outcomes that you give to your patients. So what are the challenges that exist in the current training scenario and what best practices we can adopt? No financial interest to be disclosed with respect to this presentation. When we talk of ophthalmic surgery, we need to understand a few things about how it is different from other surgical branches. There is a lot of precision that is involved in our surgeries. We work in a very small and confined space with very fine instruments. So a lot of precision is required, lot of dexterity is required, lot of hand, eye, foot, brain coordination it is required. Even a smallest amount of surgical error that can happen, a small suture gone loose or opened up, a small Descemet membrane detachment, an IOL slightly decentered, all of them can have a significant impact on the patient's outcomes in the form of visual acuity, in the form of quality of vision, and in the form of the effect on the quality of life of the patient. And we all know every AIOS and other conferences we attend, we keep on seeing new techniques and new technologies and new systems that keep coming up. So there is a constant need for the postgraduate students as well as ophthalmologists in general to continually adapt to these changing circumstances and continuously keep in the learning mode. Now, there are certain challenges in the surgical skill development and training. There are these challenges from the patient perspective, from the student perspective, from the educator or the faculty perspective, and the overall system of education per se. So from the patient perspective, there is a variability in the patients. Cataract surgery is learned maybe in a fixed defined areas, like you need to have a good dilated pupil when you start learning surgeries, the cornea needs to be healthy. So the learning happens in a predefined sets of cases. But when you finally start operating, you learn that each patient is individual. Each cornea is different, its posterior capsule is different, its sclera is different. So that surgeon adaptability to different complexities, different disease profiles, ocular profile is different, systemic profile is different, anatomy is different. That adaptability needs to be developed. As I said, fine motor skills are needed, and it is very, very challenging to master all these skills without extensive training. In many of the scenarios, institutes and colleges, they do not have an observer's tube. There are no CCTVs, no displays, and no fancy gadgets. So it is very, very difficult for the faculty or the senior who is assisting to actually guide, supervise, observe, and take charge of when necessary. So this limitation of ophthalmic microsurgery, that is one-person microsurgery concept, it limits immediate supervisor intervention, which increases the risk of surgical errors and complications to some extent. However supervised and informed the surgery may be, ethical concerns do exist about novices and trainees performing procedures on patients. And the patients are awake most of the time. We operate under local or topical anesthesias. So giving a real-time feedback to the students when they are operating is sometimes very, very difficult, because they are constantly receptive, the patients, to whatever chatter and talks and conversations they are happening during their surgeries. And the next day they are bound to tell you that they know that their surgery was done by, maybe a trainee or maybe a less experienced person. There are some inherent gaps in the curriculum and the structured training program itself. One is the curriculum is still not standardized, not very structured, and not uniform across the country. In spite of the PG NMC curriculum coming in place, it still focuses on the cognitive domain, to some extent on the psychomotor domain. But the surgical domains and the soft skills, they are still not overtly into the curriculum, still not structured. They do ask for a mention of how many surgeries and procedures have been assisted, supervised, performed, observed. But what about the quality of the surgeries done, and what about the competency? That is not mentioned. There is limited exposure to diverse surgical cases. Across the country, various geographical regions will have different patient exposures. Some areas may have more pterygium, some may have less pterygiums, more cataracts in some institute, less cataracts in some institute. So ultimately, at the end of the year, if you see the number of PG trainees that come out after having their MS degrees, their competency levels are very varying and in a huge range. There is insufficient emphasis on non-technical skills. Whenever we talk of surgical skills, we focus on how they handle the tissues, how they are using the instruments, and what is their visual outcome the next day, whether it is 6/6, whether the cornea is clear, and all those stuff. But there are a lot of non-technical skills which are associated with the surgical aspect. How they behave in the OT, how they talk with the sister, the nursing staff, the supporting staff. If the patient gets uncooperative, how they talk and behave with the students, the decision-making capability, the leadership skill in the OT. If a complication happens, how well they can judge and take charge of the situation. All those non-technical skills which form a part of surgical training, they are not there in the curriculum and neither do we teach them. There is inadequate utilization of technology because of the cost issues, infrastructures issue. Again, each institute and college has their own set of equipment. Limited mentorship opportunities and inadequate assessment methods. Till date in the exams, we just focus on the cognitive domain, to some extent on the psychomotor domain. The what and why of the different things and how to some extent. But we never assess the surgical skills. Surgical skills are never assessed. We do not grade them. We do not allow them to step up in a structured manner. So that assessment component is still lacking. There are tales which come from the student perspective from the operating room itself. Each student has a different learning curve which we as faculty need to understand. Each surgery, each complication of surgery has a different learning curve. Time pressure, again, as Dr. Naina very rightly mentioned, managing so many things on different fronts. Again, that time pressure is there. They need to cope up with the stress and fatigue. They also need to have a balance between confidence and humility. Confidence as in to take decisions and operate properly and in a wise manner with good wisdom. At the same time, to be humble enough to acknowledge their mistakes, identify their weaknesses, and seek feedback, opinion, and guidance from the mentors or faculty. So that balance between confidence and humbleness needs to be there. And of course, as I mentioned, navigating through the different interpersonal dynamics needs to be there. So how can we in different ways try to address these gaps? One is a structured training needs to be there. Training programs need to be standardized and uniform across the country and addressing various levels of skill from basic to advanced. Objective assessment needs to be incorporated. Even though it is not part of the NMC guidelines or the curriculum, at individual levels, at departmental levels, we can start incorporating assessment of the surgical skills. Various rubrics are available on the ICO portal. There are n number of rubrics for different surgeries which are open access. We can make use of them or maybe even design and validate our own rubrics. But an objective assessment of surgical skills with a continuous constructive feedback needs to be there. Simulation training, again, as just discussed, they are vital in the surgical training forum. They provide opportunities for repeated practice, allowing to make deliberate mistakes, learning from them, and it's a safe and practice environment where the students can go back repeatedly and keep performing different steps. And all this without having any patient risks. So this will increase their confidence and it will also allow them to operate with more finesse and giving more predictable patient outcomes when they actually operate on live patients. Different types of simulators are there, something very crude as like fruits and vegetables and all those things for practicing dexterity and suturing and other stuff. Then we have high-end simulators. We have, of course, the SSTC. We have the AIOS Prayogshala now. Different gamification sites are there where the students can learn different surgeries and steps. And, of course, the AR and VR-related simulators. So whenever technology is incorporated into learning, it provides an opportunity for enhanced visualization of different structures and tissues. The higher the fidelity of a simulator or a training system, more closer it is to the realistic scenario. And as just discussed, it provides an e-learning atmosphere. The students can record their videos and share it to a faculty somewhere else, maybe the cataract coach sitting there, and they can invite feedbacks and opinions. And surgeoners are, of course, there where the students can view and learn from them. And all these high-end technologies, they have this inbuilt tactile feedback, auditory feedback, and other scoring systems which allow the students to step up level by level. We need to encourage the students to continue learning and continue upgrading their skills from different conferences, enroll in wet lab courses, mentorship, of course, Dr. Usha Madam will be talking in a while, and also encourage peer collaboration, wherein they can discuss about their strengths, the weaknesses, different aspects of the entire surgical training, and they can learn from each other themselves. We also need to teach them, while talking of surgery, about the ethical practice. No matter what, patient safety has to come first. You may have promised a sutureless surgery to the patient, but on table, if you need to take a suture, they should not hesitate to take a suture. Of course, the patients need to be informed about this, but that ethical practice and decision making needs to be imbibed while the surgical training is on. And of course, self-assessment and reflection. At the end of each surgery done, the students should be encouraged and motivated to reflect on their surgery, discuss what went wrong, what was good about the surgery that they did, and how they should move about and improve in the future. And of course, patience and persistence. No matter how many failures have happened or complications can happen, the students need to stay motivated, and faculty need to keep motivating them so that they can keep improving and keep learning. So at the end, mastering surgical skills in ophthalmology is fraught with risks. There are technological demands and training gaps, but this complex nature itself demands a comprehensive approach. So at the base, we still need a structured, standardized, uniform training program, a curriculum integration, mentorship needs to be in place, simulation fidelity needs to be incorporated, objective outcome measurement, that is assessment, along with a constructive continuous feedback needs to be there, and the students need to be encouraged for reflection and for lifelong learning.